begin now with the posterior evaluation of the foot. We start with the plantar fascia. Of course, the plantar fascia is easily seen if we begin on the medial aspect of the calcaneus. The reason for that is the thickest part of the plantar fascia, so it's easily defined. And if we're looking, notice that the landmarks are the calcaneus and then the insertion of the fascia as it inserts into the calcaneus. This region right in here is where most of your pathologies occur. Above this is the fat pad. So general thickness of the Achilles tendon is anywhere around 3 to 4 millimeters in thickness from the calcaneus up into the border of the plantar fascia, this white hyperechoic area that you see here. Anything over 5 millimeters is considered more pathological. So once the long axis is seen, what we'll do is we need to look at that. We need to investigate that ligament, and we can go down distally and follow it down, as you can see. And then, of course, anisotrophy comes into play at times. So we have to toggle our transducer so we can see the calcaneus. Note again that once we've got the medial side done, we can move over to the middle side. Now you notice that there's some change occurring. This can be anisotrophy here. So we have to take into account that this may or may not be the result of actual gel contact in this area. And then we go to the lateral side, and the lateral side is a little thinner, as you can see. Again, that calcaneus is a little bit thinner right there, and then you can see the tendon on the calcaneus is a little thinner right there. That is the long axis view of the plantar. The short axis view is fairly simple. Again, going over to the medial side of the calcaneus, which is the thicker side. Again, your landmarks will be the calcaneus, and just above that landmark, from the calcaneus just into this regional, this hyperechoic regional here, from here to here, is the short axis of the plantar fascia. The reason why it's difficult to stand out is because there is no symptomatic plantar fascia. If this area was symptomatic, this area would be grossly enlarged. Go into a long axis view of the Achilles tendon. Now, it's kind of important on this long axis view that we have to be at exactly, as close as we can, at 90 degrees perpendicular. Because if we're off of that, we can get anisotrophy. As you notice these areas as I'm moving this transducer back and forth. So what I like to do is I always begin with a view where I look at the insertion. So if we look at this insertion, notice this dark area right here. This many times is normal because this is what is known as anisotrophy. Sometimes you can't get this full tendon intact. So in order to determine whether the tendon is intact, you might have to do some dynamic dorsiflexion of the foot, stretch the tendon out, and this distal part of the tendon will come through. So as we're looking at this here, as I'm dorsiflexing the foot now, and I'm moving them, you can see that the fibers are there, so this tendon is intact, okay? It should be. This is a normal, healthy individual. As I move up again on the Achilles tendon, there's a couple structures that we need to look at. So one, we need to look at the Achilles fibers themselves. And this area down here, this dark area down here, it is called Keegan's fat pad. And that's seen. Normally, if it was if it was completely dark or anechoic without reflections, that would mean that there would be a lot of excessive fluid in that area, and that's usually the result of injury or some other abnormality that could be present in that individual foot structure. So as I move the Achilles, notice, I want you to focus from here to here, that the Achilles comes in. Notice that I'm slightly, it's hard to see on this particular movement, but I'm slightly going medial to lateral, investigating that whole area, trying to maintain a 90-degree perpendicular. As I come up, notice as I come up on the ankle and foot, you still have the Achilles, and below is the soleus muscle, and over here is the hallucis. Now watch me move the big toe. Notice the hallucis where the arrow is. Then above that is the soleus, and then the more proximal part of the Achilles tendon. This area in here can be many times involved in tears, as well as the distal part of the Achilles. So as we move up this particular structure, we're continually looking for tears. Notice the dark and white muscle structure of the soleus. The white is a fatty disposition of adipose fat, and then within the muscle tendon, and then the dark part is actually muscle itself. The reason why this area is so dark is this person is well hydrated, and a lot of muscle is showing in this particular individual. As I move up more medial, I will begin to come into the medial gastroc. And now on the medial gastroc, you see a little V-shaped from here to here. And notice just below that medial gastroc, this little small hypoechoic line that goes under the medial gastroc, and that is the plantaris. Now, you can see the plantaris very well here, medial gastroc, soleus muscle. As I go up into the medial gastroc, it now takes shape. Notice that this gastroc has a little less of a hyperechoic area because this is more of a fast twitch muscle versus the psoas, which has a tendency to be more of a power muscle. Once I go up to medial gastroc, I follow it all the way up. And you continue following it up, and you can follow it all the way up into the knee joint area. From there, I go back to the mid portion of the Achilles tendon. Then I move a little bit more laterally, and then the lateral gastroc comes in. Again, you can see the lateral gastroc. The lateral gastroc comes in. There's the lateral gastroc, and there's the soleus. Soleus and lateral gastroc, they move together, notice that. Then I can continue going up the lateral gastroc. We begin with our short axis views. I like to start like in the middle of the Achilles, so that gives me a reference point. And what I look at is I find the bristle-like structures of the Achilles in the short axis. Just below here is actually the plantaris, which usually is medial to the Achilles tendon. Now notice where my transducer is. It's actually, in this view here, it's actually perpendicular at 90 degrees to the Achilles tendon. This is an important item to understand, is because if you move your transducer and you are off the tendon, this Achilles can get dark. Notice the hyperechoic and the anechoic lines inside the tendon, and they can mimic many times right here. They can mimic many times as intersubstance tears. And when you actually straighten out the Achilles tendon, you notice that there is no tear. So it's important that we be able to move that transducer where we can toggle it back and forth to be sure that we are getting the full picture of the Achilles tendon in the short axis. Now, once I have a reference point, I will usually go distally, and then eventually you will begin to see the calcaneus appear. The tendon is currently right in this region, just above the calcaneus. And as I move the tendon again, it's very difficult to see, but as you can see that tendon right in here coming in. Again, if you follow the ball here, bouncing ball, the tendon comes back in. The dark areas that you're seeing are a shadowing. It's just a drop. It's called a drop off. And now what will happen? The tendon will get smaller as the soleus come in, and then eventually, as we move all the way up, it gets smaller and smaller, and then eventually we lose the tendon, and now we're into the soleus. And from there we go medially. And then we begin to get the triangular structure that comes in, as you can see from here to here, the triangular structure of the gastroc, which is right in this particular region here. Once from there we can move up and follow that gastroc all the way up. Soleus is below. Soleus below, gastroc is more proximal. From there, we drop back down. We can go, again, picking up the soleus area. Then we go laterally, and then we'll pick up the lateral structures. So that's the lateral gastroc head. Again, we follow that all the way up, and then we'll go all the way up to the base of the knee.